Hello, welcome to Hematology and Blood Transfusion Science Lecture Series. This is a YouTube channel where we discuss different topics in hematology and blood transfusion science. Thank you for being part of what we are doing. Thank you for subscribing to our channel. Thank you for liking and sharing our videos. And if you have not subscribed yet, please, this is the right time to subscribe. Remember, keep on sending your feedback, keep on sending your comments. They are really helping us a lot. Thank you very much. Today, we are going to be discussing another exciting topic, hemolytic disease of the fetus and the newborn. My name is Dr. Ifeanyi Kafo, a lecturer in the Department of Hematology and Blood Transfusion Science, Faculty of Medical Laboratory Science, College of Medical Sciences, University of Calabar, Nigeria. Welcome to my channel, Hematology and Blood Transfusion Science Lecture Series. Let us go straight to today's lecture. Objectives of this lecture. It is expected that at the end of this lecture, you should be able to understand the pathophysiology of hemolytic disease of the new fetus and the newborn. You should be able to identify the key antibodies implicated in this disease. You should be able to define critical antibody, what we call critical antibody titer, recognize the clinical features of hemolytic disease of the fetus and the newborn, describe diagnostic approaches, and you should understand the prevention strategies with regards to hemolytic disease of the newborn. And of course, discuss the management strategies for hemolytic disease of the fetus and the newborn. Definition. Hemolytic disease of the fetus and the newborn is a condition in which the fetal or neonatal red blood cells are destroyed prematurely due to the transfer of maternal antibodies across the placenta. Now, these antibodies target antigens that are present on the fetal red blood cells. It can also result from other immune-mediated or pathological processes. And at the end of the day, you have hemolysis, anemia, hyperbilirubinemia, and associated complications in the baby. Now, hemolytic disease of the fetus and newborn can arise as a result of blood group incompatibility, maternal autoimmune disorders, infections, enzymopathy, and other causes that disrupt the balance of the fetal erythropoiesis and red blood cell survival. Now, the things that can actually lead to destruction of red blood cell or hemolysis of fetal red blood cell, it could be blood group incompatibility between the mother and the child. It can also be the maternal autoimmune disorders or infections. Even other infections like malaria can cause red blood cell hemolysis in the fetus. And also enzymopathy like G6PD deficiency and anything at all that can disrupt the balance of fetal erythropoiesis or red blood cell survival in the fetus can actually cause hemolytic disease of the fetus and the newborn. But today we are going to be focusing on hemolytic disease of the fetus and the newborn as a result of blood group incompatibility between the mother and the child. So it is a potentially life-threatening condition that is actually characterized by the destruction of the fetal and neonatal red blood cells by maternal antibodies as a result of blood group incompatibility between the mother and the child. These antibodies are typically formed when the mother's immune system is sensitized to fetal red blood cell antigens inherited from the father but absent on the mother's red blood cells. This scenario arises as a result of the baby or the fetus inheriting a specific red blood cell marker from the father, but this particular antigen are actually absent on the mother's red blood cells. As a result of that, when this antigen enters the mother and circulation, immunological response is elicited, and the mother ends up producing antibodies against these antigens. Subsequently, these antibodies can cross the placenta and can harm the baby, causing hemolysis and other clinical symptoms that are associated with hemolytic disease of the fetus and the newborn. History. Historically, hemolytic disease of the newborn used to be a major cause of fetal loss and death among newborn babies. The first description of HDN is thought to be in 1609 by a French midwife who delivered twins. One baby was swollen and died soon after birth. The other baby developed jaundice and died several days later. For the next 300 years after this incident, many similar cases were described in which newborns failed to survive. Now, it was not until 1950s that the underlying cause of HDN was clarified, namely, the newborn's red blood cells are being attacked by antibodies from the mother. The attack begins while the baby is still in the womb, and it is caused by an incompatibility between the mother's and the baby's blood. By the 1960s, trials in the United States and United Kingdom tested the use of therapeutic antibodies that could remove the antibodies that cause HDN from the mother's circulation. Now, the trials showed that giving therapeutic antibodies to women during their pregnancy largely prevented HDN from developing. Now, by 1970s, routine antenatal care included screening all expectant mothers to find those whose pregnancy may be at risk of HDN and giving preventive treatment accordingly. Now, this has led to a dramatic decrease in the incidence of HDN, particularly severe cases that were responsible for stillbirth and neonatal death. Since the emergence of anti-immunoglobulin, therapeutic giving of anti-immunoglobulin to pregnant women to prevent sensitization, the incidence of stillbirth or neonatal death associated with hemolytic disease of the fetus and the newborn has actually reduced drastically. Now, let us look at the pathophysiology of hemolytic disease of the fetus and the newborn. The two phases are the sensitization phase, and the next phase is the destruction of fetal red blood cell. The sensitization phase is actually the first phase, and then the second phase is actual destruction of the fetal red blood cell. The sensitization phase is a situation where we know what we call fetal maternal hemorrhage, a little portion of the baby's blood leaking into the mother's circulation, either during pregnancy or during delivery or during any form of invasive procedure. When this is done, the baby, if it contains any antigen that is alien to the mother's circulation, can elicit immunological response in the mother, producing antibodies. Now, the second phase is destruction of the fetal red blood cell. Now, some of these antibodies are IgG in nature, but they have the capacity to cross the placenta. So after sensitization phase, now during subsequent pregnancies, maternal IgG antibodies can cross the placenta. These antibodies bind to fetal red blood cell antigens, forming antigen-antibody complexes. The fetal mononuclear phagocyte system, primarily in the spleen, recognizes these complexes and destroys the red blood cells, leading to what we know as hemolysis. So pathophysiologically, we have two phases. You have the sensitization phase and then the destruction of red blood cell phase. The sensitization phase is a situation where the mother is sensitized against the antigen that are found on the baby's red blood cell. And this could happen as a result of fetal maternal leakages, where a small portion of a baby's blood leaks into the mother's circulation, either during pregnancy, during delivery, or during any form of invasive procedure. It can also, the mother can also be sensitized as a result of transfusion of incompatible blood. And then when mother is sensitized, the mother ends up producing antibody against these antigens. And then during subsequent pregnancies, these antibodies can cross the placenta and attach or bind to fetal red blood cell antigens, forming antigen-antibody complexes, and this can elicit immunological response. The fetal mononuclear phagocyte system, which comprises of spleen, recognizes these complexes and destroys the red cells, causing fetal hemolysis. There are certain procedures that can actually favor sensitization, and they are: number one, pregnancy. In pregnancy, when there is fetal maternal hemorrhage during pregnancy or during labor, and this scenario can increase during prolonged or complicated labor. Now, a small portion of baby's blood can leak into the mother's circulation, sensitizing the mother to produce antibody against the antigens found on the baby's circulation, but they are not in the mother's system. Another procedure that can favor sensitization is blood transfusion. When the mother is transfused with Rh positive blood, if the mother is Rh negative. Another one is antepartum hemorrhage, placental abruption, a procedure like chronic villus sampling. That is, if the baby that is involved in this scenario is Rh positive and the mother is Rh negative, or if the baby does not have the antigen like antigen K and the antigen is absent in the mother's circulation, or any of the antigens that can actually cause, and the antibody can actually cause the hemolytic disease of the newborn. Then we have the abortion, DNC, miscarriages, ectopic pregnancy. If the baby being aborted or miscarriage is Rh positive, the risk of sensitization to the Rhg antigen is decreased if the fetus is ABO incompatible. This can be explained better if you have a good knowledge of ABO blood group system and Rh blood group system. Please do well to visit our channel and listen to that lecture on ABO and Rh blood group system. It will help you to understand what we are discussing here today better. Now, a situation where a mother is A, naturally the mother is supposed to have antibody B in the circulation, and the mother is pregnant with a baby who is B. If the baby has taken the blood group of the father, B, obviously the baby have B antigens on the surface of the red blood cell. And then the mother is A negative, Rh negative, while the baby is B positive as a result of taking the blood group of the father and the Rh antigens from the father. Now, if there is fetal maternal hemorrhage and the little portion of the baby's blood leaks from the baby into the maternal circulation, remember that the mother has antibody B in the circulation, and the baby has antigen B and then antigen D. Now, if the baby's red cell leaks into the mother's circulation, the already naturally occurring antibody B that are naturally found in the mother's circulation, who is blood group A negative, will do what? Will try to attack this baby's red blood cells and destroy them, leading to reduced sensitization or stopping the baby's cells from sensitizing the mother to actually produce anti-D. So that is the reason why we are saying here that the risk of sensitization to the Rhg antigen is decreased if the fetus is ABO incompatible. Now, because we say that because any fetal red cell that leak into the maternal circulation can be destroyed by the natural occurring anti-A and the anti-B antibodies that are already there present, reducing the chances of the mother being sensitized by the baby's red cells. Now, during pregnancy, it is natural that some of the mother's antibodies are transported across the placenta and enter the fetal circulation. This is because by the time of birth, we know that newborns have only a primitive immune system. Their immune systems are not fully developed, and the continued presence of maternal antibodies help them to ensure that they survive while their immune system matures. But a downside to this protection is that by targeting the fetal red blood cells, maternal antibody can also cause hemolytic disease of the newborn, especially when you have blood group incompatibility between the mother and the child. So the maternal antibodies can cross the placenta and attack and destroy the fetal red cells. Let us look at diagrammatic explanation of the pathophysiology of hemolytic disease of the fetus and the newborn. We have the antigens on the red blood cells, and we have the antibodies in the plasma. And some of these antibodies are IgM in nature, while some are IgG in nature. When there is incompatibility between the mother and the child, the mother is sensitized to produce antibodies against the antigens on the surface of the baby's red blood cells. But the majority of them can also be IgG. And these IgG antibodies found in some blood group systems like Rh blood group system, Kell blood group system, Kidd blood group system, Duffy blood group system, and also even some other that are blood group O. These IgG antibodies have the capacity to cross the placenta. So when you look at this diagram, this is the IgG antibodies, this is maternal circulation, this is the placenta linking the mother and the child. This IgG antibody crosses the placenta barrier, enter the fetal circulation, and attack the baby's red blood cells. They form a complex on the red blood cell membrane of the baby, eliciting extravascular hemolysis. The IgG antibodies enter the baby's circulation through the placenta and form a complex on the red blood cell membrane of the baby, causing the spleen to remove them from circulation and destroy them, eliciting extravascular hemolysis. And in doing so, the anemia is induced and jaundice is formed, because once red cells are being destroyed and catabolized, protoporphyrin is being degraded, and at the end of the day, the byproduct, you have what we call bilirubin, forming jaundice, because the liver of the baby is too young to handle the rate at which the red cells are being destroyed. So some of the bilirubin form cannot be conjugated for them to be eliminated from the body. So that ended up being deposited on the various organs and tissues of the baby. And then because the red cells are being destroyed, extramedullary hematopoiesis is triggered. Therefore, the liver and the spleen are also involved in producing more and more red blood cells to compensate for the anemia that is going on in the baby. And then the heart is also overlabored. And in doing so, the baby becomes weak, becomes anemic, becomes hydropic. Some blood group systems like Kell blood group system goes extra mile of not just destroying the red blood cells, but also they target red blood cell progenitor cells, and in doing so, they destroy the already formed red blood cells and also stop the new ones from being formed, causing severe anemia. Now let's look at different types of HDN that can result as a result of blood group incompatibility. We have ABO HDFN. As a result of ABO incompatibility, we have non-ABO HDFN, and this non-ABO HDFN can be RH and then non-RH HDFN. Now, ABO HDFN, this arises when a mother who is blood group O becomes pregnant with a fetus with a different blood group like A, B, or AB. The mother's serum contains naturally occurring anti-A and anti-B, which tend to be of IgG class and can therefore cross the placenta and hemorrhage fetal red blood cells. The mother's serum, in addition to containing IgM antibodies, also have a portion of IgG antibodies in the circulation. And these IgG antibodies can cross the placenta and harm the baby. For the HDN due to ABO incompatibility is usually less severe than the RH incompatibility. Now, the reason why the HDN due to ABO incompatibility is usually less severe is because we said, when we did ABO blood group system, we said that ABO antigens are ubiquitously distributed. They are found almost in every part, tissue, and organ of the body, and even across the placenta wall. So, as these antibodies are moving from the babies, from the mother's circulation into the baby's circulation through the placenta wall, there's a tendency that they will be meeting this antigen that are on the placenta wall. And as they pass through them, the concentration will be greatly reduced. At the end of the day, a little or nothing is remained to attack the baby and the baby's red blood cell. And again, remember that antibodies in ABO blood group system are largely IgM in nature. They are cold antibodies, and majority of them are IgM in nature, and IgM antibodies do not cross the placenta. So most times, it's only a small portion of it that actually IgG in nature. And this small portion, even when they cross the placenta, meets other A or B antigen that are littered on the placenta walls. Attacking them will reduce the concentration. So at the end of the day, what actually ends up attacking the baby red blood cells is actually small. And the HDN that may result at the end of the day as a result of this will be mild or moderate. Non-ABO HDFN. The major cause of HDN is an incompatibility of the Rh blood group between the mother and the fetus. Most commonly, hemolytic disease is triggered by the D antigen, although the other Rh antigens such as little c, big C, and big E, and then little e can also cause problems. But in Rh blood group system, the most immunogenic antigen here is antigen D, although other Rh antigens like little c, big C, E, and little e can also cause problems. But the most one that is implicated in HDFN is RhD. Pregnancies at risk of hemolytic disease of the newborn are those in which an Rh negative mother becomes pregnant with an Rh positive child, the child having inherited the D antigen from the father. The mother's immune response to the fetal D antigen is to form antibodies against it. These antibodies are usually of IgG type, the type that is transported across the placenta and hence delivered to the fetal circulation. Less common cause of HDN can be as a result of antibodies that are directed against antigens in K blood group system. Example, antibodies anti-big K and anti-little k. Now, I said earlier that antibodies in K blood group system also cause severe hemolytic disease of the newborn. And this is because these antibodies not only cause hemolysis, they don't just destroy red blood cells, they also target progenitor red cells, okay? And this is because K antigens can be found both on the mature red blood cell membrane and also on the surfaces of the progenitor red blood cells. And when there is incompatibility between the mother and the child, the antibodies formed in the mother will destroy both the mature red cells and the young red cells. So they end up causing hemolysis and also depressing erythropoiesis, stopping new red cells from being formed and also causing intense destruction of the already formed one. So HDN, as a result of K antibodies, are particularly serious in nature because they destroy the progenitor red cells. The amount of jaundice that is formed as a result of this destruction is not as much as that is formed in RhD, HDN, because they destroy both the progenitor cells and the mature cells, and they depress erythropoiesis. And there's also always severe anemia. So most times, clinically, this one presents not with increased jaundice, but with severity of the anemia. So particularly most times, the baby dies as a result of severe anemia, rather than as a result of kernicterus or increased hyperbilirubinemia. Another blood group system that can actually cause HDN is anti-JKA, anti-JKB in kid blood group system, and therefore blood group system, anti-FIA and MNS and little s and P and other blood group system antibodies. Antibodies of the Lewis blood group system have not been implicated in the hemolytic disease of the fetus and the newborn. Now let's look at the clinical effect of the hemolytic disease of the fetus and the newborn. The first one is anemia. Anemia, they cause anemia Because of increased destruction of red blood cells, they cause severe anemia in the babies, depending on the rates at which these antibodies are formed and at which these red cells are being destroyed. Hemolysis leads to fetal anemia, which may progress to hydrophytalis if the hemolysis is severe. This hydrophytalis is associated with edema, ascites, pleural or pericardial effusions. Intrauterine growth restriction can also occur in some cases. Now, prolonged destruction of red blood cells leads to severe anemia. When this anemia is not curtailed, the prolonged destruction of red blood, depending on the concentration of antibody that is being formed in the mother's circulation and being transported in the baby's circulation, the prolonged destruction of red blood cells leads to severe anemia in the fetus. And as a result of that, the liver, the spleen, and other organs try to increase their production. That is, extramedullary erythropoiesis continues to occur. And then to compensate for the loss of the red blood cell that is happening in the baby's circulation. Now, the drive to produce red blood cell causes the liver and the spleen to increase in size. You have what we call hepatosplenomegaly, and the liver dysfunction can also occur. And then you have what we call the immature red blood cell, that is erythroblast spilling into the baby's circulation, giving a characteristic picture of what we call the alternative name for this disease that is called erythroblastosis fetalis. Now, looking at this picture that we have here, this is a picture that's showing the baby that is highly edematous, hydros fetalis. And then we have babies that can have the presence of jaundice, you can have yellowness of the eyes, yellowing of the skin, as a result of excess bilirubin in the blood. And then we have bilirubin, when it moves from the baby, when it moves from the baby's circulation, and tries to cross the blood-brain barrier, can also cause a permanent neurological damage to the baby, which cannot be reversed. Another critical effect of hemolytic disease of the newborn is we have what we call hyperbilirubinemia and then kinecteris. Hemoglobin released from the destroyed red blood cell is metabolized into bilirubin. We have looked at hemoglobin catabolism. If you have not listened to that lecture, please go back and listen to it. It is under hemoglobin synthesis and catabolism. You will understand that as the hemoglobin is destroyed, one of the byproducts is what? Bilirubin. And then bilirubin is yellow in nature. And that is what we see as jaundice, postnatally in babies that have HDFN. Now, during pregnancy, the level of bilirubin may still remain low during pregnancy because of the ability of the placenta to remove bilirubin from the fetal circulation. But after birth, the neonatal immature liver is unable to metabolize the increased amount of bilirubin that is being formed as a result of increased destruction of red blood cells. And instead, this bilirubin accumulates in the baby's blood, and within 24 hours of birth, the level of bilirubin may rise dramatically. And if levels continue to rise, bilirubin may enter the brain to cause kinecteris, a potentially fatal condition that leaves the permanent neurological damage in the babies that survive it. So the target here is to reduce the concentration of bilirubin in the baby's blood as much as possible to prevent it from crossing the blood-brain barrier. Because once it gets into the baby's brain and causes damage to the baby's brain, it cannot be reversed. Now, what we call the critical titer. That is, the critical titer is the maternal antibodies concentration at which there is a significant risk of fetal anemia or hemolytic disease of the fetus and the newborn. It varies depending on the antibody. Now, we have different antibodies that can cause hemolytic disease of the fetus and the newborn. So we have Rh antibody. The critical titer for Rh antibody is 16. We have anti-K, that is anti-K, big K. The critical titer is 8. The anti-K antibodies are more dangerous even at low titer due to the suppression of erythropoiesis. I have explained this before. Now, anti-little c and anti-little e, the critical titer is 16. While anti-big E, the critical titer is 32. Now, for ABO antibody, the titer levels are not routinely measured because hemolytic disease of the fetus and the newborn as a result of ABO incompatibility is usually mild and self-limiting. I've tried to explain this before. Then critical titer for less common antibodies like anti-Duffy, JKA, anti-KID vary, but are generally considered significant at 16. Now, let's have a closer look at laboratory diagnosis of hemolytic disease of the fetus and the newborn. Now, we have the maternal testing and the fetal and neonatal diagnosis of hemolytic disease of the fetus and the newborn. The maternal testing, you do the blood group and then the antibody screen. Then the indirect Coombs test is directed at the mother's serum, and then you have goes extra mile to look at when antibody is identified through antibody screening and antibody identification. We have actually discussed this antibody screening, antibody identification extensively. Please do well to go back to our channel and look up the lecture on antibody screening and antibody identification. It will help you to understand how you can do antibody screening in the laboratory. But here, we are saying that as part of diagnosis of hemolytic disease of the newborn, maternal testing. Remember, in the mother's serum, you are talking about the presence of the antibody. So what you do on the mother is to do the blood group, and then you screen for antibody, and then if there is presence of antibody, you identify the antibody. Remember, indirect Coombs test is done on the mother. Now, when the antibody is identified in the mother, then there is need for us to know the concentration of the antibody. And that leads us to what we call antibody titration. The antibody titration is to determine the critical titer level of the antibody found in the mother. Remember that I have just mentioned that critical antibody levels for different antibodies like anti-D, KEL, and all that. So you need to know so that you will know whether the baby in the womb is at risk or not. Now we have the fetal test, the fetal or neonatal test. Now on the baby's blood groups, blood, you also need to do the baby's blood group, and then direct Coombs test is done on the baby. The direct Coombs test is done on the baby to check if the red cells have been sensitized. And then you can also estimate the full blood count if you can, or you go straight to do the hemoglobin concentration or packed cell volume to check for a presence of anemia. And then estimation of bilirubin levels. You have to do the conjugated and unconjugated bilirubin and then total bilirubin to quantify the amount of bilirubin that have been formed to know whether the baby is at risk of connecterus or not. Now, there are also what we call fetal monitoring. Fetal monitoring involves using Doppler ultrasound of the middle cerebral artery, MCA, to assess fetal anemia. Amniocentesis for bilirubin levels in amniotic fluid can also be done, but this is rarely used today. But what is also used today is what we call the Doppler ultrasound of the middle cerebral artery to monitor the fetal anemia or to assess fetal anemia in the baby. The direct Coombs test. Like I said earlier, the direct Coombs test detects maternal anti-D or maternal antibodies that have been already bound to fetal red blood cells. First, a sample of the fetal red blood cell is washed to remove any unbound antibody. And then when the test antibodies, that is the anti-human globulin, is added, they agglutinate any fetal red blood cell to which maternal antibodies are already bound. This is called direct Coombs test because the anti-immunoglobulin binds directly to the maternal anti-D immunoglobulin that causes the fetal red blood cell in hemolytic disease of the fetus and the newborn. That is, the anti-immunoglobulin that you added binds directly to the maternal anti-D that have already coated the antigens that are on the baby's red blood cell. In the presence of HDFN, direct Coombs test is positive. And remember, direct Coombs test is done on the baby. Direct Coombs test is done on the baby. Indirect Coombs test is done on the mother's serum. Direct Coombs test is done with the baby's red blood cell, while the indirect Coombs test is done with the mother's serum. They actually find antibodies in the mother's serum. The mother serum is incubated with antigen-positive red blood cells. If any antibody, example anti-D, is present in the mother serum, they will bind to the cells. The cells are then washed to remove all free antibodies. When anti-immunoglobulin antibodies AHG are added, they will agglutinate any red blood cell to which maternal antibodies are bound. This is called the indirect test because the anti-immunoglobulin finds indirect evidence of harmful maternal antibodies. Now let's look at what happens during the prenatal visit. At the first prenatal visit, you'll type the mother sample for ABO, the ABO antigens or blood group antigens. You check for the presence of ABO antigens, scale antigens, RH antigens, and other blood group antigens. And then you do what? You screen for the presence of antibodies. When you have done that, you identify these antibodies. And then if at the end of the day, if the patient is RH negative, then 2 doses of RH immunoglobulin at 28 weeks is given, and also at the point of delivery. The lady is also given 2 doses of RH immunoglobulin to prevent what? Sensitization. But if at the end of the day, the patient is RH positive, nothing is done. But if other antigens are negative, you also do what? Do the same. Remember that alloantibody investigation involves 2 distinct procedures or 2 parts: antibody screening and antibody identification. Antibody screening and antibody identification. We dealt with this topic extensively when we treated antibody identification. Please do well to go back to our channel and listen to that lecture on antibody identification. But just know that when you screen after doing the ABO and blood group test for the patient, and you do your antibody screening, you must identify the antibody. And then when you must have identified the antibody, the next thing is to do what? To check for the antibody strength, the concentration of the antibody. And for you to do that, you need to do what we call antibody titration. You need to do what we call antibody titration. Now, remember that we have said earlier, the sources of maternal antibody, we have the previous pregnancy that sensitized the antibody, sensitize the mother to produce this antibody. We have the current pregnancy that you have through the fetal maternal hemorrhage. The baby blood, who is still positive, can move into the mother's circulation and keep on stimulating the mother to produce more of this antibody, increasing the concentration of the antibody that the mother will have. Then we have the previous blood transfusion and also other invasive procedures that can also trigger the production of antibody with the baby in the mother's, if the baby involved is having a foreign antigen to the mother. After you must have done your antibody screening and done your antibody identification, if the antibody identified is clinically significant, now you have to do what we call the titer. In doing the titer, you do what? You have to determine the strength of this antibody. Remember, we said something about the critical titer. Determine the critical titer. So you need to know whether this patient the level of antibody is high enough to cause harm to the baby. So prenatal titration. Why do we need to do prenatal titration? Remember that clinically significant immunoglobulin antibodies can cause moderate to severe hemolytic disease of the fetus and the newborn. The titer levels are used to monitor pregnant women with IgG antibodies. A clinical titer warrants a referral to a higher risk obstetrician team for further testing to predict the risk of the HDFN. And then obstetrician commonly increase fetal monitoring when the 2-base titer reaches for anti-D 16, for anti-K 8, for anti-E 32, and for anti-little c 16, just like I said there earlier. Now, prenatal titration, what are different methods that we can use to do titration? We have the manual tube method, the manual gel method, and the automated gel method. The manual tube method, The manual tube method, they all have the advantages and disadvantages, but the recommended method that we use now in most laboratories is the manual tube method. But research is ongoing to standardize the automated gel method because it is faster and even more specific. So the manual tube method can have subjective grading, less stable reactions, possibility of pipetting errors. The manual gel method have subjective grading, stable reaction, possibility of pipetting errors. While you have the automated gel method, you have objective grading, stable reaction, and precise pipetting. Even though that the recommended thing is manual tube method, but some laboratories are making effort to gradually move from manual tube method, manual gel, and then over to automated gel method. Then we have, let's critically look at tube-based titer. Tube-based titer, you have, that is the titration. You have to set up your tube as indicated here. You have the neat, the 1 in 2 dilution, the 1 in 4 dilution, the 1 in 8, the 1 in 16, 1 in 32, 1 in 64, 1 in 128, and 1 in 156. Okay? And then you have your AHG. Now, 100 microliter diluted plasma is placed into a test tube. 50 microliter of 2% cells are added, incubated at 37 degrees for 60 minutes. After washing 4 times with saline, 2 drops of anti-immunoglobulin G are added. The tubes are centrifuged and read for macroscopic agglutination. Now, when you look at their scoring sheet, when the tube must have been centrifuged and then read for macroscopic agglutination, when you look at your scoring sheet, you have the plasma dilution, the neat, the 1 in 2 dilution, 1 in 4 dilution, 1 in 8 dilution, 1 in 16 dilution, 1 in 32 dilution, 1 in 64 dilution, 1 in 128 dilution, and 1 in 256 dilution. So have your reaction strength. The innate have 3 pluses, the 1 in 2 dilution 3 pluses, the 1 in 4 3 pluses, 2 pluses, and then 1 in 16 0, 0, micro, 0, and 0. There's this notion that tube testing has poor precision, and because of that, most labs use run historic sample in parallel to account for lack of precision. So if you are doing your present sample, it's always good for you to include the previous sample. So looking at the current sample here, you have where you have your agglutination, the lowest agglutination as in 1 in 32, while the previous sample, you have what? And 1 in 8. So obviously, you have a 2 titer increase in the strength of the titer from 8 to 32. Another method you can use to do your titration is manual gel method. Here you have your range of reactions. 50 microliter of well-mixed cells are added to the gel column. 25 microliter of diluted plasma sample are added to the gel column, and 15 minutes incubation at 37 degrees. The gel cars are centrifuged and reactions are immediately graded. And then you can also have the reaction as seen here, 0 plus, 1 plus, 2 pluses, 3 pluses, 4 pluses, and mixed field. Then we have automated gel titration. Here is fully automated and the precision is guaranteed. The pipetting is more accurate here. Now we'll talk about the reproducibility and the precision as regards to these 3 methods of titration that I've just said here. Reproducibility can be defined as the closeness of agreement between results of successive measurements obtained under changed conditions like time, operators, calibrators, reagents, and laboratory. While the precision can be said to the closeness of agreement between results of successive measurements obtained under identical conditions. So that is why when we are doing manual method of titration, it is advised that you include historic sample to enable you to check what you are doing today. So if you have 8, the titer of 8 in the historic sample, and it gives you exactly what you obtained before, you'll be sure that what you are doing today is also what it should be. And that will also for you to know whether there's a significant rise in the titer of the antibodies that you are assaying. Now, research is ongoing on how to standardize the automated gel method, and there are no critical levels that have been established for the titer levels of using the automated gel method. Remember that the titer method, critical titer that I have stated earlier, is determined based on the tube-based titration. The gel technique, research has shown that the gel technique frequently resulted in a titer that are 2-fold times higher than that detected by the tube technique. And it's been advised that, if you do the tube-based titration and also gel titration, you can actually use an average of the result as an outcome for your patient. Now, the automated gel have been shown to be more sensitive than the tube, and also show to pick minute reactions that the tube technique cannot pick. And the difference begins to decline at higher titer, the difference between the automated gel and the tube technique. But at the same time, the tube technique remains the recommended method for titration. If and when your laboratory starts using automated gel method, it's advised that you should always include the tube technique that will help you to do what? Standardize what you're having in the automated method. And we have the critical method, critical titer here for the tube, given from ranges from 8 to 16, while for automated gel titers around from 32 to 128 titers. Now, what is considered as a significant rise in the titer? When you do a repeat at 28 weeks and you have 2 tube increase in the titer, is actually significant. 2 tube increase in the titer is significant rise in the titer. Just like the result that was shown earlier, that was done historically, the patient has 8, and then doing it currently, the patient has 32. Then there's a significant rise in the titer. What happens when there's a significant rise in the titer? When there's a significant rise in the titer, the truth is that what it tells the doctors is that the patient needs more close monitoring. It's only the gynecologists that are managing the patient that will know when to intervene in order to save the baby. So the rate at which the antibody titer is rising will tell them when to do what, intervene to save the child. We can also quantify the amount of baby blood cells that have leaked into the mother's circulation by doing what we call Diagrammatic test or flow cytometry. Prevention of HDFN. Administration of anti-D prophylaxis to the Rh negative mother during pregnancy and after delivery helps in preventing sensitization. What this anti-D prophylaxis does is that it helps to mop up any baby's red cell that must have leaked into the mother's circulation and prevent these red cells from sensitizing the mother to produce these antibodies. And there should also be universal screening during antenatal for antibodies and also for you to know the mother's blood groups. They will help us to know those mothers that are at risk of developing these antibodies. That's the avoidance of sensitization. We should minimize fetal maternal hemorrhage during invasive procedures, be it miscarriage, ectopic pregnancies, chronic villus sampling, or even DNC where necessary. Okay. Then avoid transfusing patients with incompatible blood that can sensitize them to produce these antibodies. Now, management of hemolytic disease of the fetus of the newborn. We have antenatal management where monitoring baby is being monitored by Doppler ultrasound. And then we have intrauterine transfusion when there is severe anemia in the fetus where necessary. And we have the doctors having delivering plans, timing depending on severity of HDFN. That's where titration and the monitoring of antibody rise is important when it seems that the baby is at danger of being getting to hydrophytalis or stillbirth, then the doctor will intervene and bring out the baby. So there should be a delivery plan. Timing depends on the severity of hemolytic disease of the fetus and the newborn, and also the fetal condition. Postnatal management: when the baby is born with hemolytic disease of the fetus and the newborn, we have phototherapy to help in handling the hyperbilirubinemia. Then we have the external blood transfusion for severe anemia and reducing the high bilirubin levels. And then we have intravenous immunoglobulins that is given to reduce antibody-mediated hemolysis. These are things that will help us to do what? So this helps in managing hemolytic disease of the fetus and the newborn. But the crucial thing here is that prevention is key. Prevention is key. The prevention is key here in that every pregnant woman, every young girl should know their blood group. And then you should also, if you're negative of any identified antigen, you should try as much as possible to prevent yourself from sensitizing yourself, especially anti-D, anti-BK, anti-little c. And then anti-D is common here and has been shown to cause more severe hemolytic disease of the fetus and the newborn than other antibodies, followed by anti-BK. So we should try as much as possible to prevent ourselves from being sensitized by knowing our blood group. And also when we are negative, we should follow all the prescribed doctors' advice that will help us to monitor you during pregnancy, and also make sure that both the pregnant woman and the baby are safe. Thank you very much. I hope you enjoyed the lecture. I also enjoyed it. Please send in your questions and your comments. Don't forget to subscribe to our channel. Thank you.